Okay, so thank you, Tom. Thank you, Boston, for putting together this symposium. I think we've been discussing this slide for the whole meeting. It is very clear that angiography is providing, enough information to do very good drug-coating balloon procedures, but perhaps angiography is, currently not enough, and we can gain more information from intravascular imaging and perhaps also from physiology. In patients with interstitial stenosis, it is very clear that imaging is providing unique insights regarding underexpansion, type of tissue, and all these can be corrected. But there is less information in the value of intracoronary imaging in de novo lesions. In theory, using intravascular imaging, we can identify the underlying substrate, so we can improve our lesion preparation, perhaps with plaque modification. We can also perform measurements, so the severity, the length of the devices, and especially the size can be more accurately measured. And then after the intervention, perhaps we can get further insights to optimize the results of these procedures and eventually to decide when and how a bailout strategy should be performed. The problem is that we have very little data in this regard. This is the most important, the only randomized clinical trial suggesting the value of intravascular imaging for drug-coating balloon angioplasty. This was a population of high bleeding risk patients with de novo lesions, and very interestingly, the use of IBUS was able to select larger devices, so they obtained a larger acute gain. But importantly, in this study, the late lumen loss was reduced. So this is kind of unique in interventional cardiology, this connection between the acute gain and the late lumen loss, but this is the study as published. So at the time, I reviewed for an editorial the information available. And there were like 10 observational studies emphasizing the value of intracoronary imaging to guide these procedures, but with, I would say, rather weak data. In Transform 1, there is beautiful information, then probably we will be seeing more information coming from this study now, and it is very clear that the information you can get by OCT, you can see the residual plaque, you can see the strength and the arc of the dissection, and you can see the lumen. So it is impossible to anticipate how this beautiful information is not going to be of use to optimize our procedures, but we are not there. From this study also we learned that this paradox can be explained by the efficacy of the balloons. So perhaps with this technology, the old paradigm, the more you gain, the more you lose, is challenging, and this is also important information coming in this regard. So this is a small but beautiful study with serial intravascular ultrasound trying to assess predictors of left lumen enlargement after a DCB therapy. And it is very clear that the mechanism, according to this small but beautiful study, was both total vessel enlargement but also plaque regression. And they've, in this small study, they were able to identify that the presence of no flow limiting dissection was a marker of this phenomenon, was a predictor of late lumen enlargement. So I will share with you very briefly two recent studies presented in TCT regarding lesion preparation. So if we review the data of the AGENT IDE randomized trial, there were a subset of patients that require complex lesion preparation. So we are going to see here the difference between the two strategies, plaquette axial coated balloon versus balloon angioplasty. The lesion preparation was quite, robust with cutting balloon, scoring balloon, but also with intravascular lithotripsy and even laser, as you can see here in this part of the study. And it was quite clear that the benefit of drug-coating balloon are compared with POVA was more clear in patients after complex lesion preparation, probably because the underlying calcification or complexity of the lesion was a major factor. Now, the other thing is that the use of special balloons. I've been always very critical with this. I mean, before stent implantation, I mean, all this story about plaque modification, you know, I've been always reluctant to accept that. But I have to say that in the DCB era, I personally think that this is of value. So my experience, and you know, I'm a believer that you know, using special balloons can be of value. But you know, experience and you know, believers is not probably good enough. So we need data also in this regard. So this is an observational study comparing the results of a scoring balloon versus POVA before DCB. In this study, it was very clear that the results were superior after the use of a special balloon, and the use of these balloons was an independent predictor of a nice angiographic result. And my personal experience is that when you are dealing with a de novo lesion, you are getting out a good result before you know, going to bailout stenting. You should always do scoring with a scoring balloon or a cutting balloon, because in some cases, and I got plenty of anecdotal cases, you change and you are able to obtain a very nice result. So Inticity was also presented this small, but again, very interesting randomized clinical trial, the Nature trial. So basically, patients were randomized to cutting balloon angioplasty with a Wolverine device versus a standard balloon. The idea was to, you know, to get the optimal angiographic criteria, and these are the results. So in this small study that we just saw in San Francisco, you can see that the angiographic visual assessment was not different with the two strategies, and this is coming from a small but a randomized clinical trial. There was a trend, a strong trend, for better minimal lumen diameter by QCA after cutting balloon lesion preparation, and this is of interest. And there was also a trend for a better minimal lumen area after the procedure with the cutting balloon. So this is interesting, but the key issue is not only the acute result, but whether or not plaque modification with this technology is able to improve the effect of the drug at the vessel wall. So long-term data is required. So what about late lumen enlargement? We review for this editorial the information at the time, and well, obviously late lumen enlargement is basically negative late lumen loss. This is especially important in de novo lesions. This is especially important when we use plaquetaxel versus Limus drug-coating balloons. The reason behind that appears to be twofold: an increase in total vessel area, but also plaque regression. This phenomenon is more frequently found in the presence of dissection, or either angiographically or using intravascular ultrasound. And this appears to be associated not only to better late angiographic outcomes, but also with superior clinical outcomes. So just to finalize, we performed last year this meta-analysis, putting together 6 randomized clinical trials, small trials, but the trials available at the time, comparing plaquetaxel coated balloon with Limus type Limus drug coating balloons. And this was before the newcomers, before Solution, for instance. But there were randomized clinical trials, and it's very clear from this meta-analysis that, at least with the data at the time, that the use of plaquetaxel coated balloon provides a better minimal lumen diameter, percent diameter stenosis at follow-up, reduces late lumen loss, and clearly is a factor to explain late lumen enlargement. So thank you very much for your attention.